that shifted the maze. No single part of you was ever the same. Now we're so tired by the things we have seen. All we've forgotten, only visits and dreams. How I misunderstood. Here I stand undressed. Here I confess my doubt. Did you know that I would? From this fractured lens, we're unveiled again and again. Sometimes I get the feeling I'm lost. Just hiding it is never enough. Now I find in every mirror a ghost. Only once I saw the killer, once I saw the killer up close. Heaven's over now. I know it's gone. I know it's over now. If colder heavens come, carrying me further down, where our madness rests, where I'll have less to doubt. All I misunderstood, my abandoned friend, our parade is already left. Sometimes I get the feeling I'm lost. Just hiding it is never enough. Now I find in every mirror a ghost. Only once I saw the killer, once I saw the killer. Sometimes I get the feeling I'm lost.
Right. Okay, yes. You ready? We start? It's fine. Okay, thank you. Okay, so. Welcome to our symposium on flu vaccines, part of the solution for a healthier and more productive society. It's organised by the International Pharmaceutical Federation and the International Federation of Pharmaceutical Manufacturers and Associations. It's part, as I'm sure you know, of the World Immunisation Week. That's a week when the public and the private sector come together to raise awareness of the fact that vaccines do work. And today we're going to look at one of the vaccines, the seasonal flu vaccine. And there's some striking statistics here. Globally, flu results in about 5 million severe cases and 500,000 deaths annually. And according to the WHO, immunisation can reduce the rate of influenza, the so-called morbidity, by 60% and mortality by 80%. So, of course, the question is, why is the uptake so low? And particularly amongst at-risk groups. So we're talking about people who've got underlying chronic conditions, heart disease, diabetes, asthma. Why are they not getting their flu jab? Similarly, with older people who, of course, have the issue of age, but also they may have one of these chronic diseases. And so why are they not getting the flu jab? Well, I'm delighted we have a panel of experts who have all the answers. They're going to outline some of the challenges. We're going to look at some of the strategies. What needs to be done to improve uptake of the flu vaccine? I will also, of course, ask you for your reflections and what you think, and please do ask questions. Let me turn to our distinguished panel. First of all, Wen Qing is the head of the WHO Global Influenza Programme. Please just say a few words about the work that you do.
Hi, good morning, everybody. So my name is Wen Qing. I'm from the World Health Organization, we're headquarters in Geneva. I'm heading the WHO's influenza program. So the work of WHO, which is an UN public agency, where WHO develops norms and standards, develop evidence-based policies, will coordinate activities of public health, to protect people, to reduce mobility and mortality associated with diseases.
Thank you very much. Matthew Downham, you're representing the IFPMA. Tell us a little bit about this organisation and also your knowledge about the influenza vaccine.
Thank you. So good morning, everybody. So I represent the IFPMA Influenza Vaccine Supply Working Group, which is an organisation of industry and associations that work together to facilitate critical influenza vaccine supply issues. We work very closely with organisations like the World Health Organization to support vaccine distribution, vaccine supply, both Northern and Southern Hemisphere. I also work for AstraZeneca MedImmune within the Research and Development Group, where we are responsible for developing the flu vaccine strains through to accession C for further manufacture. And I also am the Vaccines Europe Influenza Working Group Chair. So that's my background.
There we are. I hope you've remembered all of that. Jane Barrett is the Secretary General of the International Federation on Aging. Please tell us about your federation.
Good morning. Good morning to you. The International Federation on Aging is an international non-government organisation that has members in 73 countries. We represent some 65 million older people through a unique network of government, non-government, industry, academic and older people. Our goal is to be a global point of connection of experts and expertise to influence and shape policy. The IFA is committed to improving the uptake rates of adult vaccination as a critical element to the healthy ageing strategy globally.
Thank you very much. So we have the messengers, and now we pass on to the deliverers. And there's Erica Earhart, registered nurse and analyst for the International Council of Nurses.
Hi, good morning, good morning. So the International Council of Nurses is actually the oldest healthcare professional organization in the world. We're a federation of over 130 national nursing associations around the world. And we work to deliver evidence-based nursing policy on a range of global health issues. Immunization is, in fact, one of our key strategy or strategic areas. And so we work to influence global health from a nursing perspective.
Thank you very much. And of course, the other deliverer is the pharmacist, and Luc Besançon, the CEO of the International Pharmaceutical Federation. Please tell us about your federation.
Thank you. Good morning, all again. The International Pharmaceutical Federation is the world organization gathering 139 national associations of pharmacists and pharmaceutical scientists, representing 3 million pharmacists around the world. And as Erica's organizations, we are here to help having evidence-based policies to support improvement of health through the activities of pharmacists. And so immunization has been one of the focus of our work of last year and continue over the coming few years around how pharmacists can contribute in terms of improving uptake of immunization, facilitate immunizations in collaboration with the other healthcare professionals.
Thank you very much. Evidence-based, obviously a key word, and so let me start first of all with the WHO. And can you tell us what are your recommendations, first of all, for these at-risk groups, these people who are suffering from the non-communicable diseases?
So, as I said earlier, that the WHO develops the evidence-based recommendations and policies. Well, as early as in 2003, WHO actually through the World Health Assembly had a resolution to improve the uptake of seasonal influenza vaccines. So, they are high-risk groups identified. Although, in the resolution, it highlighted the elderly group, not necessarily was at-risk group, but it said the target of 50% coverage by 2006, and up to 75% of the elderly population in 2010. So, in 2012, WHO reviewed again the evidence gained at that time and developed a position paper, WHO position, about seasonal influenza vaccines, and listed the group of underlying medical conditions as was priority group to receive seasonal vaccines. So this is the current WHO policy. But of course, there are a lot of activities ongoing to get more evidence to look further into who or which are the exact risk groups that should receive seasonal vaccines.
So you're still doing some research on which are the at-risk groups. Do you have a percentage? You've got a percentage very clearly for the older person that you want a 75% vaccine coverage. What about the at-risk groups? Are you anywhere near quantifying?
No, so far we don't have the specific figure with regards to the coverage of the different risk group. And if we are talking about risk group, we also need to be clear which exactly the risk groups. The group with diabetes, the group with cardiovascular diseases. It's quite more complicated than just to say risk groups.
And where is the evidence? Do you have an idea at which one of these is most at risk? Is it the cardiovascular? Is it the diabetes? Is it the heart?
Well, indeed, the activities are still going on, and this is called burden of disease, because we need to understand the burden associated with influenza disease. So the activity is still going on. I hope by the end of this year we would have a clear idea. But through literature review and other studies, there are a couple risk factors were identified. For example, the age, the chronic pulmonary diseases, cardiovascular diseases, and underlying neurological conditions, etc., diabetes, there's a long list. But this is still the work in progress.
Understood. Thank you for making that very clear. Now, of course, we do have a statistic for the older person. Now, it's 75%. Why did you come up with 75% vaccine coverage and not 100% vaccine coverage?
Well, that target was set in 2003, and probably people remember at that time. I don't think people had such level of awareness of influenza. There's no zoonotic outbreak yet. At that time, probably it's only or just at the start of the highly pathogenic H5N1. So the awareness certainly is not there yet. So even at that time, WHO said 75, it's really very high already. With regards to why it's 75 instead of 76, I think probably this is based on discussion with expert groups, like this might be the target that we should move towards.
So it's the target that you should, if we take, because we have a figure there of 75%, it's the target that you want to move towards. How well is it implemented?
Actually, we have experts also sitting in this room, like Brian, did very good research on this, and also in WHO, we have different source of data with regards to uptake of seasonal vaccines. I don't think we've reached the target yet.
Well, during the question and answer session, yes, please let's hear from that, because yes, I understand that there is very much to do, and a completely non-evidence-based, unscientific approach from myself here. When I was back in the UK at Easter, I was asking various friends, parents of friends, have you taken the flu vaccine? And these are relatively educated people, and it's very much not sure whether it's effective. Oh, I took it and I had some side effects. So there is always this sort of issue, and please tell us, how effective is it? How do you make sure that it is as effective as possible?
Well, influenza is a pathogen, excuse me, really different from all other pathogens, because influenza, the virus, is constantly evolving. And in order for a vaccine to be effective, the content in the vaccine will need to be matched to the circulating viruses. And also, because of the current technology, it takes 6 to 8 months to produce a seasonal vaccine, which means the decision of what need to go into the vaccine need to be made 6 or 8 months before the actual use of the vaccines. So from that perspective, indeed, the vaccine effectiveness actually varies from year to year, depending on how much the content in the vaccine matches with the circulating viruses. Well, in recent years, fortunately, many countries started doing scientific studies, the vaccine effectiveness studies. In years with ideal match, the vaccine effectiveness is around 50 to 60%, which means that 50 to 60% of the infection can be reverted by or through the vaccination approach. And in seasons, if the match is suboptimal, then the effectiveness will be very low, like 20% or something. So it varies.
Varies, okay. And is there so many strains out there and they're sort of mutating so fast? Is that also an issue, that it's difficult for the vaccines to catch up with all these different strains?
Absolutely. Well, this is always a challenging for developing vaccines, from the public health stream down to the production. Everything is under very tight time frame.
Thank you for being, I think, very clear about the challenges in actually producing these vaccines and making sure that there is a match. And as you say, the target, if I've understood it, is 50 to 60% effectiveness. Let me move on then to Matthew. So there's somebody at risk. There we are. You're from the UK. I'll take my friend's parents or my mother, who's 89. What would you say to that person about why they should take the flu vaccine, if they're an older person or if they're in an at-risk group?
So fundamentally, the flu vaccine is almost like an insurance policy. There's no guarantee in any particular season that you will or you won't get the flu, that you'll contract the flu. However, if you are vaccinated, you're obviously in a better position to be protected against the flu. And one of the things that the IFPMA-IVS is trying to do is support and advocate flu vaccine uptake together with some organisations. I mentioned earlier the WHO, but we are also working closely with agencies that specifically reflect to the non-communicable diseases populations and the elderly populations, to try and support that as much as is possible and advocate flu vaccine uptake in these key areas. So it's all about sort of education, it's kind of promotion, it's trying of understanding the concepts, and the concepts that Wenqing has just mentioned there, the need to change the flu vaccine on an annual basis, depending on how the strains have changed, how they've drifted and shifted. And it's that advocation that flu vaccines are a protective mechanism, and that you are in an at-risk group, and that is the key protective insurance aspect.
Because I think the IFPMA has come up with some really startling facts that for those people with these underlying conditions, it increases the risk of hospitalization by 3 for those who have diabetes, by 5 the risk of a heart attack after a respiratory infection, risk of a stroke, and a risk of death for those with lung diseases. So those are some really strong statistics that have come out. But as you say, it's about getting that message across. And I'm just wondering also whether there's a case, as ever, with the economic benefits, because there's a lot of people who if they're older, they will go into hospital, they may get one of these, they may have one of these underlying conditions, they're hospitalised, and then, of course, there's even more costs.
So there are economic aspects here, of course. You know, if you have an increased hospitalisation rate or increased death rate, sadly, then there are economic aspects relating to that, particularly hospitalisations. Maybe in the winter months, if there's an increase of hospitalisations, then it puts pressure on the hospital to cope with that, as well as any other kind of diseases or incidents that happen more frequently in the winter period. So there are strategic and financial arrangements from a hospitalisation perspective, particularly with these populations, and supporting them from a medical perspective as well, their underlying conditions.
Obviously very difficult to get international figures, and I think in our second discussion we'll have some from the US, but to make these cases you have to have an awful lot of data.
True, yeah, absolutely.
Jane, Secretary General of the International Federation on Aging. So why is it important that the older person gets vaccinated?
Let's first of all put this in context. By 2050, there'll be 2 billion people over the age of 65. So many of us here today and listening will fortunately or unfortunately be 70, 80 and 90 in years to come. But a longer life is not a prize if your function is compromised. And adult vaccination, vaccines, is one of the critical elements of healthy ageing. It's really a no-brainer, isn't it? Because, you know, even if it's 50 to 60% efficacy, then that's efficacy that you wouldn't have. Because we talk about older people in the context of how do we create the environment to enable them to do what they value. And the value of being healthy means you can stay in the workplace longer, you're able to look after or care for your grandchildren if that's your choice. You know, the role of older people in volunteerism is very powerful. So there are just 3 reasons why older adults and older people should be vaccinated.
Yes, indeed, because they're part of the community and there's this community response, indeed.
Yes.
I think that resonates very clearly. And I would ask you too, do you know of any studies where you can see the economic case for the older people who have the credible role in society? It doesn't stop when you retire at 65 on actually
I think it
having
increases, doesn't it, Claire? I think it increases. Professor David Bloom and his colleagues at Harvard University have done some very important work, calculated return on investment of 12 to 18% for adults being vaccinated. Now, this is only the beginning of what I think is a body of work that needs to be done. Because I think when we talk about financial constraints, the health dollar, the bottom line, we're not only talking about hospitalisation with influenza, we're talking about the corollary. You know, the home care services that will be required, the family that may actually have to support that older person, you know, in the community. So therefore, absenteeism from work. So it's complex calculations, but what we do know is adult vaccinations are critical to the public health campaign and critical to a nation's productivity.
Yeah. And as you say, I mean, the message we're getting is more research, more data, but the data we have shows that it's a very useful step. Now, with the older person, what is the challenge in actually, you know, getting to them, to reaching out to them? Because as we know, some older people have mobility issues, they live alone, they're isolated.
Look, we know a lot of the barriers. Some of the barriers are cost and mobility, but my guess is that some of the barriers that we don't understand how to action is, I'm already healthy, I don't need the vaccine. It won't happen to me. And I had the flu last year and it didn't put me to bed for more than 5 days, so there's misperceptions about what influenza is and does and the consequences, but it's also the messages. Saying to the general public and older adults, it's flu season, go and get your flu vaccine, does not give that critical message of the implications for this disease and the consequences thereafter.
Certainly. Well, let me move from the messengers, and we've seen that there is a role really for communication and communication campaigns, and for weeks like the World Immunisation Week in trying to get this message across. Erica, if I can ask from a nurse's perspective, largest clinical providers of this vaccination, and so how can you reach more of, first of all, tell us about the older person.
So nurses are largest clinical provider of immunization and of vaccines. And on top of that, we also work across a continuum of care. So if we're looking at it from a life course approach, from the beginning to the end of life, but also within a care experience from the beginning of diagnosis, let's say, of a chronic disease until sometimes palliative care. And so we also work in a lot of settings. So we have the most opportunities of most healthcare providers to actually have that interaction with patients. And so when Ching and Matthew and Jane all talked about the why and why it's important, and I think the nurses are the deliverers, and in addition to pharmacists and physicians, are the deliverers of that message to then the target groups. So I think it's very, very important for healthcare professionals themselves first to believe in it. So that would be step one is and I know we're going on to this in the next session, but education in healthcare professionals of the risks, of the importance of flu vaccines. And then there's two access pieces, I would say. Older adults, at-risk populations, there's an access piece to how they can access the flu vaccine, but also how we can access them to transfer that information and that knowledge. And I think increasing health literacy is also a big piece. So having the individuals being able to identify, what does this mean to me? And why is this important to me? Like Jane said, I feel healthy, I'm well, I got it once and I had some side effects and I don't really feel like going through that or waiting in line. So I think it's about increasing health literacy and the why is it important to me piece.
And in fact, if I can just sort of pick up, so if you have that person in front of you, what do you say to them? How do you navigate? Because of course, as we've seen, it's a work in progress. We've got, yes, we should have 75% coverage. We've got, yes, there's 50 to 60% effectiveness. It changes every season. There's all of these, yes, but, and you have to do the yes and. So what do you say to that person?
So we know that the WHO recommends, first of all, vaccination is not a perfect tool. We know that there are risks associated with immunization with vaccination, but we do know that it is the best way to prevent influenza. And so I think getting that message across and dispelling myths is very, very important. There's a lot of myths around what does at-risk mean? What do these numbers really mean? So for example, in I think the 2014-2015 year, there was a bit of a mismatch between the circulating virus and the vaccine, and so it dropped down to about a 23%. But I mean, 23% is still a very significant number if you're looking at, will I end up in the hospital? Will I have 5 weeks out of work? Will I be able to take care of my children? I mean, so it's about conveying to people what that 23 or 60% actually means. And dispelling myths around, there's been a lot of dangers, side effects.
So you're really having to navigate through the data, the myths, and to get that message across very clearly. Now, also, I think it's interesting to know, because you're the International Council of Nurses, are nurses able to deliver this vaccination everywhere, or does that depend country by country?
There's a very big difference between countries and even in countries. So in some countries, for example, in Canada, it varies by province, in fact. You can have anywhere from a nurse being able to prescribe, for example, nurse practitioners prescribe vaccines, deliver vaccines, down to nurses not being able to administer them at all. Very important piece, I think, if we're looking at how to influence policy around standing orders. So we know that having a standing order and having nurses and pharmacists being able to deliver immunization on the basis of standing orders is going to increase access.
A prescription.
Correct. Right. So
Divided by the same language, there we are, the
right.
Canadians.
So a prescription that exists based on a list of characteristics that the healthcare professional assesses when the person is in front of them, that allows them to administer the flu vaccine. And so increasing nursing autonomy to be able to deliver vaccines is a big piece. And I think that we have to make sure that there are several entry points in the healthcare system where people can access vaccines, but also, and when we move on to looking at pharmacies, which is I think a lot of healthcare professionals can model on, because in the US and Canada we've had this excellent model of pharmacists delivering vaccines, is this opportunistic, the opportunity. So instead of, there's two pieces, it's the individual knowing why and when, but it's also about integrating immunization into all different types of healthcare services, whether it's a well baby visit, whether it's an annual checkup. So
indeed, very important that the deliverers coordinate, and there's nurses who, and you, I assume, if I just come back to nurses, that you would prefer, you are advocating for a greater role for nurses. You think that nurses everywhere should be able to deliver this
absolutely.
vaccination.
So from the perspective of the International Council of Nurses, of course, it is within our scope of practice to administer vaccines. And so we are advocating for a full role in that, to be able to practice within our scope of practice and to be able to make the decision within the context of the country's policy, of course, to administer vaccines. But I don't think that increasing autonomy of nurses is taking away from the delivery of immunization from other healthcare professionals. I think we all need to work together and in collaboration. And knowing that if there is a missed opportunity, a colleague of mine will be there to intervene.
Well, let's segue very nicely to the pharmacists, Luke. So what sort of role are pharmacists currently playing in delivering this vaccine to older people or the at-risk groups? And what would you like to do? Would you also like more autonomy?
So originally, pharmacists have been highly involved in two pieces. One is around the advocacy part to promote immunization. Second has been around supply chain and providing a safe supply chain so that there's no break of cold chain management, which is quite critical, especially in developed and developing countries either way. Then what we've seen is in 1958 in Argentina, and then it grew in Tunisia in 73, in South Africa in 1991, and in the US in 1994, pharmacists started to be involved as immunizer, meaning that they started to be immunizing patients. And that is based on one simple consideration. The number of people that go to the pharmacy every day. For instance, in Europe, you have 48 million patients that go every day in a pharmacy, which is quite substantial in terms of providing opportunities and easiness and convenience of access. So when policymakers realize there's a drop in terms of coverage against flu immunization, there's clearly here an opportunity for involving pharmacists, and we've seen an increasing number. Now we've seen that in our latest data from 2016, we had 860 million patients that are living in a country where pharmacies are able to immunize. And that's where we would like to offer that when there is a need. And unfortunately, in most countries, there is still far from the objective of WHO to reach 75% of coverage. To have the support of pharmacists in addition and in collaboration and coordination with our other healthcare professional colleagues.
And it does actually, if you do the advocacy right, you do see a greater uptake amongst these at-risk groups.
Yeah, we have various type of advocacy for even in a way country pharmacists are not able to immunize. Like in Belgium, they had a sticker at the flu vaccine time, where to remind patients at risk based on the delivery of the medicine, are you immunized? But also we've seen that in countries like in Portugal, where 10 years ago they have started to immunize through pharmacy, a big intake. 40% of the immunization in Portugal are made through community pharmacy. And in Ireland, we know that about 16% of the patients that are immunized through community pharmacy is the first time they've ever been immunized. So there's an element around increasing uptake through pharmacy by reaching out to people who may not be immunized. It's not instead of other healthcare professionals. It's trying to have a diverse approach to really aim with one objective, which is public health.
So in fact, you are now turning your pharmacists into advocacy people in the fact, do you actually want them proactively to, when people come who might have one of these underlying conditions, to say, well, you would be a very good case?
Yes,
for
that's what
the
we have
flu
shared
vaccine?
as best practices. Turning into advocacy, and obviously, if at the same time you do advocacy, you can offer the immunization, it's easier. You don't have to think, you don't need to get. Another interesting data in the US, about 40% of the immunization that is done in community pharmacy is during outside normal working hours. It's at evening or in the weekend. So it's also a way to reach out to people who are sometimes too busy just to get half a day off to go to the GP or to a nurse and just to get this immunization. And in other cases, pharmacy offer immunization with the help of nurses in their own community pharmacy.
I was going to ask you about that because you can see the advantages of the pharmacies, that it's convenient, it's accessible, but there might be some reservations. Well, you know, are you trained? One, to give me the advice. Who are you to give me the advice? But also, can you actually deliver this vaccine? You're not a doctor, you're not a nurse.
So in 2011, at WHO and FIP, when we developed together what is the roles and function of pharmacists, we're including administrating vaccine there. And in 1994, USA started to immunize by pharmacists, and we developed, our groups in the US developed a whole programs around that. The feedback we have is that there's never been a case that was not properly managed there, and so there's really good evidence. And the feedback, I think what you are aiming at is two elements. One is what is the public health assessment of it, and CDC is praising pharmacists as the second most used
The
source.
Centre for Disease Control.
Yeah, Centers for Disease Control of the US is really highly supportive of that role. And the second element, when we ask patients, have you experienced that? Are you willing to go back to a pharmacy for next year? They say yes. And they say, why is it? It's because it matches with my life. The healthcare in that case is not trying, don't need to try to follow the healthcare. The healthcare is matching with my life.
So I assume that you're advocating for a greater role for pharmacists. And did you say that in Belgium that they weren't allowed to do this? And so
yes.
This is one of the countries that you will be targeting.
I think it's based on the needs of the country. I think that's important there. What we are aiming is to respond to a challenge in the country in terms of insufficient uptake. And there's also, priorities of different elements. So I think it's the country-based origin analysis that would really help to define what is the best solutions for that country. Some countries where the current system is already providing 80% of coverage, you might say there's maybe no need necessarily to change the system, but if there is under that level, then you might say we need to change, we need to reach the objective.
Matthew, if I can come to you. So there is obviously much to be done at a policy level. And I mean, what would you like to see governments do to prioritise and support, vaccinations in these at-risk populations? Obviously, there's the issue of increasing the role of the deliverers. But what else can be done?
So I think governments do play a key part here. National authorities do play a key part. I mean, thinking through to the UK vaccine programme, that is specifically designed to vaccinate young people, young children up to the age of 17, with the aim of not only protecting them against flu, but protecting their aunties, their uncles, the people within their family and communities. It's a government-led campaign. So I think national authorities, need to be very closely involved and be proactive in supporting those particular campaigns, irrespective of which means of access that is facilitated in a particular country. And Luke really picks up on a key factor there, and that is accessibility. It's ease of receipt of a flu vaccine, irrespective of whether it's on the high street in a pharmacy, in a supermarket or whatever, or through the nursing communities, etc., or through maybe care homes in the ageing populations. So what needs to be thought about is the multiple ways that flu vaccines can be delivered, can be provided to the community, and there's different avenues to support that. And I think, as I say, national authorities can certainly help with that.
Wenjing, I mean, again, yes, budgets are tight. I'm sure your member states and the ministers of health are always saying that they're being squeezed. I mean, what is your message to member states, the Ministry of Finance or the treasuries? You know, why should they prioritise? Do you go and advocate that this is absolutely key?
So I think in this room, we're talking about influenza vaccine. We look at this one piece. But I think for a government, we need to put ourselves in the context. So there are much more than one priority vaccine there. So for the government to develop policies, they need to have a whole spectrum of evidence, of data, for them to decide whether this is the way forward. So for that, WHO is helping member states to gather the evidence, to gather the information, and a government really need to think not only for the time being how the vaccine could work in terms of cost effectiveness, but also for long term in a strategic way for the health security perspective, whether my investment now would be able to serve for the long-term health security purposes, for example, for the next pandemic preparedness. So this is somehow where we're trying to help member states to do.
Yes, indeed. There's the health security message, which we know resonates quite well with some member states. Jane, I wanted to pick up because we've seen that there are missing parts in this puzzle, and you were mentioning earlier this missing link, this driver, that even though the healthcare professionals, nurses are trusted, pharmacists are trusted, the WHO is trusted, everybody is saying that prevention is better than cure. So what is missing here? Why is this message not landing?
One of the things that we haven't talked about is, the return on investment for the older adult. I can't think of too many champions that are standing up for older adults being vaccinated. I think that's one part of it. And will they? I'm not convinced. The more strategic approach is to start talking about a life course approach to immunisation. And it's in that life course approach that we can argue for the contributions of productivity of various times in your life. When we come to, and in that, we don't have a narrative about what's happening now in terms of immunisation and healthy ageing. There's no narrative. The narrative needs to be about function, about contribution, and about growing older and being able to do what you value. I take the example of if grandparents were told that they really need to think seriously about the flu vaccine because it would impact their grandchildren who they were looking after, that would resonate. So while we have public health messages, I'm not yet convinced that we have the right message or the right pipelines for that message. And I do agree with Erica, it's about health literacy, but it goes beyond the literacy. What message will resonate with my parents in Australia? Is that the same message that will resonate with those in Spain or Italy or some other country? So there's a lot of work that's being done around efficacy of vaccines and the development of vaccines, and the opportunistic manner in which we are creating, but we don't have the right message or the pipelines, or at least we don't have the evidence to support the right pipelines and messages.
Yeah, no, that's interesting. I can see that if a grandparent was told, you can't actually go and look after your child if you're not vaccinated, wow, that would get some headlines, at least where I come from. Now, of course, it may not be ethical, and we can look at some of those issues. But yes,
I'm not
sometimes
saying that,
people...
all right?
Yes, understood. That's me putting words into your mouth like a former journalist. But yes, you can see that you do actually need perhaps some very strong messages.
Yes.
To these people, where it really resonates with the heart. Yes. Well, thank you very much for your contributions. I think it's most probably time to ask the audience for what they've heard. What do they think about the arguments they've heard, the data that is there? Please do feel free. Ask any question. I always say, as a former journalist, there's no such thing as a stupid question, but I'm talking about myself. I'm sure you are incredibly well informed, and I know that this gentleman, I think, was the one that you're from the IFPMA. I've seen you on the videos, sir, but perhaps you would like to tell everybody who you are, who you represent, and what your question is.
I'm Bram Palash. I'm a member of the IFPMA IVS task force. I'm a consultant on influenza nowadays. I worked in one of the vaccine manufacturers for 30 years, 25 on influenza. I want to share with you some reflections on things we have heard. And one of the things is about the effectiveness and the variation in results on a yearly basis. And that was linked correctly to, for instance, the antigenic match. Sometimes we have a match, sometimes we don't have a match. So that's why the WHO work is so important to do this viral surveillance. But I want to remind us on something which Krista Nicol in 2004 said, maybe we should stop talking about relative vaccine effectiveness, but about absolute numbers. Because if you're talking about relative effectiveness, we're talking about 50% or 60% or 30% or whatever the percentage is. But suppose you have a vaccine which is able to prevent a person against each and all influenza infections. Then you have a vaccine which is 100% effective. It doesn't exist, but suppose if you use that vaccine in a year that there is very low, or for argument's sake, there is no influenza around, it will not prevent influenza infections, not because the vaccine is not good, but because there is no flu around. So you can have a situation where you have a 100% effective influenza vaccine with a 0% effectiveness. In other words, what does that percentage of effectiveness tell us about the qualities of the vaccine? But what it does, it induces doubts, skepticism, all sorts of issues around these vaccines. And it is true that from a yearly basis there's variation in benefits because there are so many non-vaccine related issues as the final outcome of a season. So you have variation in benefits. But what is true also is that each year you have a huge public health benefit by using the vaccines. If there's low influenza activity, if there's high influenza activity, it's more or less. But each and every year there's a huge reduction of hospitalization, serious mortality associated with influenza. And that is a message which we can use. And that is a message which people much easier understand than it's 50% effectiveness or it is 20% effectiveness. What does that mean? So we focus the discussion on vaccine characteristics which are only partly vaccine characteristics.
So I'll ask perhaps from the WHO, what do you think? Have we got our communication messaging wrong?
Well, actually, what Bran was talking about is about the communication strategy. And it's not just how to present these figures, but also we need to take one step back to see with regards to the communication. because influenza vaccine is not one-off, I think that's English word method. It's really a continuous one, which means they need to have trust in people. And in particular these days, with these internet technologies and messages, the information can be, it's just worldwide. So how to build the trust? When we are telling people, oh, this is useful, it will protect you, probably also need to tell people, in particular those having scientific background of the associated risks, about the actual expectations that they should have. It's not just you have the vaccine and that's all. This type of message. And also along with the development, for example, the recent debate about the issue associated with repeated vaccination. This is still a scientific debate. These are the things probably really need to be very transparently communicated to the audience so that the audience could have the trust. And then they will be more open to receive this message and to continue continuously. Year by year.
And indeed, we know there's so much skepticism about vaccines that's circulating, and it's about getting, the true facts and not the alternative facts out there. Luke?
I think one element also is that all the effort that WHO and the industry makes in selecting the good strains and increasing the effectiveness does only produce public health if it's used by the patients. So that's maybe it's very simple and basic to say. Thus, considering all this process, how it will be delivered by whoever is allowed in the country to deliver immunization, that I think is as important as making sure that the vaccine is protected 100%. Because if it's protected 100% but it's not used, they will have no effect at all. And so the question also is, how do you get a return on that investment and that collective efforts so then it really translates into protection? And so that's one element. Second thing around the trust. I think trust is really crucial. You have different polls around who is the most trusted person. Usually the firemen are the most trusted person. I don't know if we should involve them, but they're like healthcare professionals, they are involved in protection against fire. And the fire in that case is flu. And then followed by usually very similarly nurses, pharmacists, doctors in the ranking. So how do we leverage that? And because sometimes also health authorities have challenges in trust at national level. Whether it's legitimate or not, the same for the industry. So I think it's also part of how do you build a coalition of stakeholders to really say, we believe that vaccines is not only good for you, but also good for me.
Yeah. I mean, that's interesting, isn't it? Because it just makes me think of polio, which is almost being eradicated, and you have to use the community leaders to get the messages across to those affected communities. Otherwise, it just doesn't get across. Let me bring in Matthew and then Jane.
Thank you. So, I mean, I think this is a really good discussion. I think another aspect that the IFPMA has considered is how to personalise the risk of flu, benefits of flu vaccination. In other words, it goes beyond the acute infection. It goes to protecting not only those with non-communicable diseases, but the frail, the elderly, as well as your own personal self. And it's a kind of method that's used quite a lot in the healthcare industry, is getting people to do like video diaries or to personalise the message. You know, if you're an asthmatic, you have an increased risk of certain kind of diseases or complications if you don't get vaccinated.
Testimony.
So personalise the message to make it real, to make it understandable, because often, you know, the science, dare I say it, and the efficacy figures and all that kind of aspect is difficult to, you know, digest and comprehend. Yes. But if you personalise it, it turns the table round, and that's something that IFPMA, IVS has certainly considered.
It's basic communications theory, as I'm sure you know, that I think it was Socrates who said if you want to persuade people, you can have logos, the facts, you can have the ethos, the credibility and the trust, but you need the pathos, you need to be able to stir emotion, and you need to be able to really get somebody to think, yes, this affects me and why. Jane?
If we want to ensure that the person gets the message that, yes, it affects me, we actually need to have older people at the table. And many times when we're talking about, you know, vaccines and uptake rates, etc., not patient organisations, because we're not patients. Older people are not patients. You know, older people are not sitting at the table. So industry, as well as NGOs, as well as government, need to appreciate that older people, as a subpopulation that's growing everywhere around the world, are legitimate stakeholders at that table. And our voice is equally important, because we bring our expertise to the table.
Yes, as an older person, I will go out of my neutral role and say yes. And with the ageing population, indeed. Erica.
So we talked a lot about the science, and we talked a lot about ease of access and having it available at pharmacies and well baby visits and all this. But I think we have to remember that we aren't robots. So humans aren't going to take messages and go, yes, sir, yes, yes, ma'am. And so, and especially now, I think more than ever, people are health literate. People know how to navigate healthcare systems better than they ever have. They know why. They're asking questions. They want to own their health more than ever. And so that is a really important piece, as well as we can do the delivery and we can talk about the science, but we really need to recognize that people are owners of their own health and their own health care. And I guess developing narratives around the importance of the flu vaccine that can be delivered to healthcare professionals and then passed on to policymakers and patients. So Jane, you talked a lot about narrative. So it is really creating a narrative around the importance of immunization.
Yes.
And just on narratives, there's some really interesting work across generations going on, you know, about hip-hop narratives of younger people, you know, linking with older people. So it's not the standard message that's going to work anymore. We're in a new environment, and we actually need to really start pushing the boundaries of not only the content, which I think we need a lot of work on, but the delivery and who's delivering what. So it's going to take a lot of work to improve uptake rates, because I think we're way behind 75%. And as we said, shouldn't we be asking for higher? Shouldn't the ceiling be a bit lifted?
Yes. Luke, yes, because you have two hats, because Luke is not only the CEO of the International Pharmaceutical Federation, but has a higher diploma postgraduate in communications. So there we are. All of our solutions are there.
Well, I mean, I'm from my work for that master, it was around risk communication of immunization. One key element for me is also you don't see the value of your immunization. You don't receive an SMS to say today you would have had the flu if you were not immunized.
Yes,
and so the challenge is that how do you make that visible, not on the population analysis, because that's, you know, epidemiologists are very good at measuring that, but how do you personalize that assessment to say, well, I don't know, we should maybe receive an SMS, 40% of the patient should receive an SMS of 60%, and just say, you have been prevented from a flu this year.
What do you think of that idea? Yes, there we are. And Sarah is writing this all down. She's actually creating a narrative as we speak. So thank you very much for that question. Excellent. And yes, if this gentleman could say who he is and his question.
Thank you. My name is Riyad Badia. I'm civil society activist in Geneva. I'm former NGOs coordination office in Geneva. I'm still supporting IFPMA since being registered in Geneva since 10 years ago. Yes, a symposium just before WHO General Assembly every year. But let me open parenthesis, because when WHO General Assembly or the UN General Assembly decreed a worldwide day or a worldwide week, it's very important for experts on this topic to be together in this opportunity to talk together. And this is the reason what we are here today in this room. This is worldwide week on immunization.
Indeed.
And immunization, it is also other diseases and endemics and pandemics. We can talk about also HIV. What I want to raise, and I appreciate what I hear, as I hear, vaccine is the way. It is one of the way. It is the best way. It is the exclusive way when it is for newborns. Yes, but when we talk about mortality, there is distinction between morbidity and mortality from 0 to 3 months, I think, or from 0 until 5 years old. But here, it is the prevention strategy, and it is also strategies for governments, for states.
And your question is?
My question is coming. I'm finishing. Because I know that non-communicable diseases in WHO, it's very important program partnership, but maybe it includes vaccines. But what I want to raise mainly, because it is also concerned older persons, and here it could be prevention, but it could be one of the best way, vaccines. I want to raise, because as you said, Mrs. Moderator, governments, and recently, yes, there was a very important program on vaccines for many governments with intergovernmental organizations, and the regional bank concerned millions of newborns and children. So I want to talk, because as I hear the gentleman raise good example on Belgium and Portugal's, but we are living globalization
Ireland
area.
and Portugal, I think it was. I think Belgium, there's still some
We
work
are
to do.
living
But
in
if I could just ask you for your question.
My question, we are living globalization area. It's better to work in the global level. So recently, I think with Gavi and the regional government and the regional banks, it was very important, a program on vaccines. So my question, it's better to working in globalization area, and we should wait, we should take this problem from the humanitarian perspective. Just after natural diseases or post-armed conflict, it's opportunity to work. So it's better to globalization area.
Okay, so we need a global and international approach. Is that my understanding of the question, Luke?
No, there's two elements here,
Yes.
maybe. In terms of globalization, one is that healthcare systems are very much national-based or provincial-based. So if you look in some country where pharmacists and nurses and physicians have difference in numbers and proportion and ability even to do something, particularly in that field. So that's where we have to be careful about whether this is applicable on the ground. I think, idea models are great, but what we want is something that is matching what is already existing. And this reflects culture and other elements. As for the integrated approach that you are referring to around immunizations and NCDs and other elements, I think the elements around SDG has been one part around trying to have a global approach.
The Sustainable Development Goals, I'm
Exactly.
sorry, all of these
Sorry,
acronyms
yeah.
sometimes need explaining as we're being videoed.
But the other key element is eventually it's also to reflect what are the priorities for the country. And so immunization against the flu is an important piece, but eventually the expert, at least from FIP side, is on the ground, because that's where most people know what is really relevant, what is the priorities based on the local needs of the people. So in some countries, maybe there's more work to be done around NCDs because it's a more prevalent element. In other, in terms of infection or in terms of prevalence of HIV, that's some of the element that is where we need still to adjust global policies into what is really makes sense at a national level.
Thank you. Jane.
Just a quick comment. I think that we need to be very careful about saying this at-risk group, these NCDs, these are people with complex comorbidities, full stop. They have a level of function, and that function enables them to be autonomous, independent or not, and require some small amounts of services or some extraordinary amounts of costly clinical services. So I always come back to what is the person's functional ability and how do we create an environment, both systemically but also on an individual basis. So my thought is, yes, sure, we do need, global guidelines. However, the work has to be done at a national level and sometimes within nations because every situation is completely different.
Yes. Please.
So indeed, just to add on to what the gentleman will commentate, for influenza, it's not just one entity can work. It's really type of, as Luke said, it's collective efforts. WHO being a public health convening body, so we've been starting looking at public health issues, but along the course, we have to engage all our partners, like we've been working closely with the manufacturers in order to produce vaccines. In the 2014-15 event about the mismatch, again, WHO is working with US, with BARDA, to looking at all the trends from the first was the surveillance to the actual vaccines, all these different steps, including the supply chain, indeed, how to improve all these process. So I think there is a content here. Seasonal influenza is one, but put it in a broader context of health security, probably would further improve, let's say, the priority level in countries.
Thank you very much. Well, I'm now just going to ask for the soundbite moment, and the lady who's tweeting will very much like this, because this is 10 seconds, 140 characters. In fact, you can have 30 seconds, but I really would just like to hear from everybody to conclude this first panel before we move on to the second panel discussion. Luke, magic wand, what's the one thing that needs to be done to improve the uptake for at-risk groups?
Coordinated approach with pharmacists and other healthcare professionals being involved.
Super, great tweet. Erica.
I would go back to developing narratives, both for healthcare professionals and for patients. The real so what, why, what does it mean for me?
Jane.
Older adults being true and legitimate stakeholders in improving the uptake rates of adult vaccination.
I think it's to consider the multiple opportunities to improve accessibility and to encourage leadership from governments, national authorities to provide support.
I would say that countries, in particular in the developing world, will start developing tailored policies that suitable for its country with regards to introduction of seasonal influenza vaccines.
Ah, yes, a whole nother discussion about the lower income countries. Thank you so much for your wise words, and we can see that from the communicators in the room, there's a lot of work to be done to really improve the flu vaccine and make sure that these uptake rates improve. Thank you very much, everybody. Have a 2-minute We will, as Matthew has just said, this is round 2, but it's a very civilized boxing match here. So if I may ask you to take your seats for what is the next very important panel discussion. Fighting flu is everybody's business, which I think is a great headline. And I'm delighted to say that we've been rejoined by Luc Besançon, CEO of the International Federation of Pharmacists. We've got again Matthew from the IFPMA, and delighted to have the Secretary General of the World Medical Association, Ottmar Kloiber. And Ottmar, just tell us very briefly a little bit about the World Medical Association. Who are you? What do you do?
Yeah, thank you. Good morning, and thank you for inviting us here. The World Medical Association is the umbrella organization of currently 110 national medical associations from all parts of the world. So we are a professional organization, and our core is working together on the rules of the profession, but we also take care of our social and economic environment in which medicine and healthcare is being placed. And of course, things like prevention, and the care from pandemics and health security are important issues for us as well.
Yeah, thank you very much, because what is interesting here is the role that doctors play in delivering this vaccination. We're going to talk about healthcare workers more generally and whether they actually get this jab themselves and what is their role as advocates, but also what about making sure that everybody gets this jab, and is the workplace the place to get it? Because again, it would seem that the take-up rates are pretty low in the workplace. There are a lot of myths out there. We mentioned some of those myths in the first panel discussion, but Ottmar is going to tell us from his research what the challenges are. But Ottmar, if I can first start with you, just tell us what we know, because we've seen that data does have a role in building a case. What is the scale of influenza in the workplace?
Yes, influenza has huge effects in the workplace and in the economy. And let me just make a statement not to be misunderstood. First of all, we are physicians, and our first concern is about the health of the people. So it's not talking money. It's simply the fact that we believe that being healthy is better than being ill, and that prevention is better than doing cure. But we have to talk about the economy as well, because I think there are also misperceptions about the economic effects of as well immunizations as of diseases. And there we can see that and those studies are mainly from the US, that we have certainly more than 200,000 of excess hospital days that are produced by influenza, which could be to a large part avoided. We have about 30,000 plus death a year, which varies greatly depending on the severity of the influenza that rolls over the country. But we are not talking about a small disease. This is nothing to be neglected. It has a major impact. And of course, that comes not only with human suffering, it comes with cost. And that is something what many employers have observed. We're living in a time where employers have also to care about their staff. It's not that it was 100 years ago. If somebody was ill, you just would fire him and then would carry on with another one. You as an employer have to take care of the continuity in your process, in your production, in your service delivery, and that means health of your staff has become kind of a production factor, actually. And that means it is a value to look for that and to invest. And that is what many companies now are doing. Nearly all of the bigger companies, for instance, in the US, offer the influenza vaccine to their staff. And they are keen to include this in their wellness programs and offer this for them, because they know exactly that there is a lot of sick leave days that you can avoid, and the cost of that in the US has been estimated that it is probably more than 16 billion per year.
Wow.
of lost earnings.
Yeah, and 70 million lost working days, I think.
Correct.
I saw, and that's 17 US billion or million lost in earnings.
Billion that would be.
Wow.
But that is only what you have with the lost days. Let me tell you another story. I'm listening well, kind of nostalgic. I'm still listening to the radio of my home place in Germany, in North Rhine-Westphalia. Whatever they do when I'm standing in the morning and having my coffee is they tell you, number one, how much traffic congestion they have after news. Number two is they tell you also which trains are not running. And here's some interesting observation, because until 2 years ago, they just said the train is not running. Since 2 years ago, they tell you why the train is not running. And what you see in the influenza season is there's a lot of trains not running because the train conductors, the engineers, are ill. Now, this is one person, one suffering, one loss of income at that time. But he is carrying thousands of people in the trains, and the trains are being cancelled. This is an additional economic damage that has been done that so far has nowhere been accounted of, which we also have to take care of. And there have been companies like the local transportation in one city in Germany, in Karlsruhe, which nearly had to close down because most of their bus drivers were ill. And we see this, and now coming from a physician perspective, we see this regularly with the flu seasons, that hospitals are not able to take up new patients because they have too many sick leaves in their staff, or they have a too high rate of patients coming in, which are blocking the beds with severe influenza. So there is a huge loss in economy with that.
No, I love that idea of local radio explaining the why. I just think it would be very long in the UK, where there are many reasons why the trains don't work and various things. It would be shorter in Switzerland. But yeah, no, I think it's a superb, it would be really superb, is because they've got the flu, so that's why you can't get to work. What is interesting is, of course, because there are, these strong economic arguments you've mentioned, it's the big scale, but it's on offer, especially in the US, but the vaccination rates are low. I read that 18% of 1,000 US companies vaccinated about 50% of their employees. So there we are, it's there. The employer decides that they want to have a healthy workforce. So why are these workers so reluctant to take it up?
I think these are the myths which are around, and what we see, especially in the affluent countries, is, and unfortunately with a pretty well-educated population, that they have concerns which are in the end completely irrational. Now, some of that is because of misinformation, of alternative facts which are circulating about this, and also a difficult understanding of what risks really are. Now, if you look to that, those are absolutely unfounded. The risks of the vaccination, of the immunizations, are extremely low. The benefits are very high compared to that. And I agree, the numbers when we say, oh, it's only 50%, the protection, and so this is completely minimum. 50% of 30,000 or 36,000 deaths in the United States means in the end 18,000 people that have been saved, that are living, and certainly a big number of which had only minor illnesses with that. So these things have to be better communicated, that people understand.
That even if you're healthy, you need it, and even if it's not recommended by a doctor, you still should go and have this vaccination.
Yes. We, of course, would advocate for having the vaccination, the immunization strategy as part of your health plan that you have with your family physician. And that includes, of course, all other immunizations as well. But that should be a regular exercise to go through that and see where I'm protected, where do I need protection. And certainly influenza is one of the big parts in that, because it has to be done annually, it has to be repeated, and actually I think it's of value for everybody.
And it is, the doctors then there is a role for them to be more proactive, because I think the statistics, unlike journalists and politicians, the doctors have very high trustworthy rates. Nurses may be even higher, but the doctors are 84%, which I think is very good news. So, you know, the doctors are trusted. So what can they do to be more proactive in getting that message across?
Well, we are arguing with our colleagues in the first place they should reflect about their own status in the first place. We think that is of high importance because they can lead with example. And when they can lead with example, it is much easier to bring this message to patients and to convince their patients that they should be immunized themselves. I have mentioned already that in workplaces like hospitals or clinics, this has also an economic effect because it leads to a loss of work capacity if people are not immunized. And therefore, many of the workplaces, hospitals, for instance, have started to have programs on that. Some just by informing, telling, and repeating this message, which is very important. Some even having some carrot and stick approaches to that by either telling those who have not been immunized to wear a face mask, which is a symbol in the first place, you know, telling there's something wrong with me because I have not taken the immunization. Or in a positive way, they have a sticker and saying, you know, I'm protected and I protect you. Because this is the double side effect of having this immunization. There are more aggressive methods of saying, well, you can't work here if you're not immunized. We would be a little bit careful with that. I think in the first place, it's a matter of leadership that you have to extend to your staff. And in many places, that really works. And that is picking up quite rapidly, thanks God.
So it's mandatory as a last resort, but
yes.
You really, and it's interesting, some of these deterrent methods, you may want to pick up on that because we will ask for your reflections. And so why would a doctor who really does understand the benefits, why would a doctor not be immunized?
Well, in the end, I think doctors are humans and have the same ideas, feelings, and the same vulnerability to misperceptions as others as well. But certainly what we have seen in talking to health professionals is, number one, they think, well, I'm not getting sick. You know, this is an optimism of why you can make it into a hospital because you believe you're not going to acquaint these diseases which are around you, which of course is wrong. You can get sick.
Yeah, they think of themselves as the healers rather than the patients.
Correct. Number two is they don't think themselves as spreading the infection. Which of course is wrong because they say, well, the people are coming to me because they're ill, and they don't think about that they themselves are in a place where it is very likely that you also spread diseases. So there is a second misperception, a second thing that is wrong. And then, of course, you as a physician, you know a lot about side effects of vaccines and things that have gone wrong, which occur, and that's not a secret. But we have a kind of an enlarged vision of the side effects, which is wrong with that because it deters us from, or it distracts us from having a clear view on what the real risks are. And the real risks are really very, very minimal. So this perception is also wrong. So it's misperceptions which also exist with the health professionals.
Yes.
Now, this is true for affluent countries where access to vaccine is not really a problem. We have a different scenario in poor countries. In poor countries, this is simply not offered because of the cost, which of course is cynical because many of them are themselves immunizing patients there, but they themselves are not being immunized. And that is indeed a very ridiculous situation, which we also have to counteract. But both situations exist.
And we heard from WHO about the risk of pandemics, indeed,
Yes.
in these lower income countries. So there's obviously still a lot of work to do so that the people who are preaching this message actually are converted and get the jab. What about the workplace? Because you would imagine that if you work for a big company, it's quite easy to organize. But what if you're a small company and there's a lot of small, medium-sized businesses, because there are cost implications, everybody's running on very tight profit margins. What would you say to them if they're a small business?
Nevertheless, even if the profit margin is very low, the investment has a very high return. In the past, I would say much better than a bank can do, but nowadays that's not really surprising. But the investment is really high. It has a very high humanitarian return on investment. It has a very high economic return on investment, so that is well invested money. There are more and more countries, especially here in Europe, which have also a very good offer of occupational health services for small companies, and they can deliver that, which is quite good and easily accessible, but it has to be promoted, and it has, especially for the influenza immunization, has to be done annually, so it should not be forgotten with that. And you're right, large companies are much better off because they can have a program running through. But as I said, there are good models. In France, for instance, where we are working, there is a very good occupational service and they fulfill the European requirements. Germany, that's the same. And I think that is a model that with very low cost can be rolled out everywhere.
And I assume that at the World Medical Association, you have a program to vaccinate your staff.
We are very aware of that, and this is for us not only a matter for the influenza, but also for all kinds of immunizations that we offer and provide to the staff, because we are traveling to many countries of the world and we are exposed to all kinds of health problems there. So we think this is really essential to have something like this.
I mean, if I can just open it up, because of course you have to lead by example. That's one of the big issues here. Matthew, what about the manufacturing in industry in general? Perhaps, I don't know whether you can talk about other countries or just the UK. What is their policy on offering this flu jab to their staff? Because of course they're in the front line handling it.
Exactly. So certainly, manufacturers, particularly flu vaccine manufacturers, have very active wellness programs. Omar's mentioned some of that already. Part of that wellness program may include offering flu vaccines to their employees, to their workforce, and not only to the workforce, to the people who work within the four walls of their industry. But we, for example, at the facility I work at in Liverpool, we have an active program not only to vaccinate the workforce, but also the children of the workforce. So we have a program where the children will be brought in and will be receiving vaccinations as well. So it actually goes beyond just the actual workforce. And the concept there is, of course, if you as we were saying a little earlier for the UK vaccine program, if you control the flu disease within that population, the young population, then indirectly it controls the rate of flu uptake in the older population, including their mums and dads that maybe work at that particular facility. So we do lead from that example perspective, and we do lead in that particular way.
I was just going to ask you, I mean, do you think it should be mandatory? This whole issue that employers, as part of their social compact, that they have to offer the flu vaccine?
I don't know about mandatory. I mean, I could imagine insurance companies kind of weaving it into their terminology in some manner or form. Sort of the necessary steps to safeguard the wellness and health of your employees, because it is becoming such a key kind of factor now. And I think it needs to be, the opportunities to improve flu vaccine rates within the workplace needs to be considered. I mean, we've talked about the large companies, but I think small businesses are equally, if not more, vulnerable. If somebody within, say, a company of 6 or 7 people, if one of their staff gets the flu, then who covers for them when they're away? It's easier to do in a company of several hundred or several thousand people. But if you've got a company of 6 or 7 or 10 or whatever, it's a lot harder to cover for whatever activity or multiple activities that one person did.
Yes.
We have in the different industries, we have sick leave rates, something between 5 and 10% when it comes high there. A lot of that happens also during the flu season. So, I mean, it's a no-brainer. Just one per person. One sick leave day that has been saved makes the deal. You know, this is really a no-brainer for entrepreneurs. So if you can count to 10, you will find out that this is of high value to you.
And of course, pharmacists are entrepreneurs in many countries. So what are the recommendations from your federation?
Well, I think there's two elements there. One is around the value in the workplace. I think you need to consider in two elements. One is the impact of that leave. And so healthcare professionals who have an impact on all the patients, if they're not able to be there, it means that for other colleagues it's more work and eventually it's delaying access to care. The second is whether you are a vector of a propagation of disease. If you start to consider that matrix, you would certainly have more than half of the population that match one or the other. I mean, the train example is a good example. On maybe he doesn't met a lot of people as he's a train conductor, but he has strong impact of not being there. So what we have seen is a number of the pharmacists in hospital, for example, in the US have led campaigns toward their colleagues to say, have we all been immunized? So not only among pharmacists, but also with doctors, nurses, and so on. So for instance, our American associations called American Society of Health System Pharmacists have done that campaign there as a good way to say, you know, it's our collective responsibility as carers to ensure that we are interested and we are committed to protect the patients by preventing us to be sick, but also preventing us to be a vector of infection. I think this is really around these two angles that the pharmacists are usually considering that. Remembering the number that I give you, 48 million patients that are visiting a pharmacy every day in the European Union, it means also if the pharmacists are not immunized, there's 48 million risk of infection. And similarly, I don't know how many there is in doctors' visit at the GP's office, but you could easily have this kind of number there. And keeping in mind that those who visit healthcare professionals, whether it's in the emergency rooms or in a hospital or in a community pharmacy or it's a GP office or a nurse office, most of them are already sick. And so you don't want to add something extra to their weaknesses that they are experiencing by other medical condition. So that's really the elements to why we are so much pushing, and I recommend all pharmacists to be immunized. And I'm immunized also, I must say. So also the element around providing example, also saying, you know, and proud to be immunized as well.
You have to have the T-shirt and the badge. Yes, that's the typical journalist question. And your immunization certificate, do you have one? But I'm just wondering, is there of the healthcare workers, I mean, again, we're categorizing, it's a very broad, we're even mentioning the fire service and the ambulance service. Are there particular healthcare workers who you really should be, we know we want everybody, but are there some that are more at risk of transmitting the disease than others? Is there a priority, or is it just everybody?
The priority lies with those who have a high person-to-person contact, clearly. I mean, if you are working in an office, even as a healthcare professional, and you don't see patients on a daily basis, your risk to acquire and to be a vector or step out the disease, so to speak, is lower, of course. But if you have person-to-person contact, be that in a hospital, in a clinic, in a public health service, then you are number one on the list and you should be immunized.
And that just makes me think, if we move to the general population, where you have people who are working in close contact with each other, we think of the call centres in Europe, but also we think of India. I don't know whether there are any recommendations for that sort of environment where it's important that the workforce actually get vaccinated.
Again, the question here is what is the individual risk there, and if you want to prioritize that, you of course would go again for those persons which have a high person-to-person contact, whether that is, for instance, a train conductor who is going through the train, checking on your tickets, whether that is a bus driver who sees everybody coming into the bus and talking to them, or whether that is a physician there. Those are the ones which are first in line. If you're sitting in a call center and sitting in a box and not talking to anybody in person, your risk is probably lower. Nevertheless, my personal advice would be for everybody, get immunized because it may save you a very bad experience. And I can tell you from my own experience, having a flu is not really funny.
Yeah, I think that is the issue, isn't it? That people don't think that the flu is serious. I think in the UK we even have this expression man flu when men are pretending that they're ill and oh yeah, it's man flu, you know, i.e. not very serious. So yes, again, that's a communication issue here. Well, I'd very much like to hear from the audience your thoughts on what you've heard. We've seen that there are in some instances deterrent measures where healthcare workers who haven't been immunised have to very clearly show that they haven't been immunised, which I think is an interesting approach. But please, your thoughts on what you've heard about actually improving the uptake of healthcare workers and also, as we say, fighting flu is everybody's business in the workplace. Yes, Erica.
We heard a lot about deterrent methods and wearing a stick or not. But I'm thinking of being a nurse. Pardon me. I also had the flu 2 weeks ago, so that's sort of the remainder. I'm also thinking of being a nurse in a very busy hospital, having 6 or 7 patients running around, working, 60, 70 hours a week. I guess I just want to hear maybe your thoughts about some very practical ways of encouraging extremely busy nurses, extremely busy doctors, pharmacists, real practical ways to increase uptake, considering the fact that we have high patient caseloads, that we have very limited hours, low staffing.
Yeah. I think this is a very important question, and actually in many countries which have already, at least on a financial term and policy term, a very open access to that, the practical access is important. And my recommendation would be not to send the employees to get the vaccine, but to bring the vaccine to the employees. So do this at their workplace so that they have no inconvenience in getting it. You don't have to have wait times for that. It's brought to you. And that, by the way, is much more economical because you have to have only one person who has to travel to them instead of 1,000 persons travel to the one person who gives the vaccine. Some countries do that. Other countries still have to learn.
Mm-hmm. Yes, Luke.
I think also law sometimes allow it or not. So that's also around how law allows and facilitate eventually.
Then change the law.
No, exactly. That's my point. The second element, I think, is also using the other opportunities. So, for instance, most healthcare professionals have a duty to have continuing education. When they go to do continuing education, it's also an opportunity to also offer that on the spot as well, or before taking the lunch break. Something that anyway you have to wait for. So as you have to wait sometimes 15 minutes to get for the anaphylactic shock, it's a good opportunity to get something there to combine different elements. So then it really makes it easier for them in their work life, and it's not something that they have to take 30 minutes off from their busy time.
Now, it's interesting because, of course, we have this perception, don't we, of nurses really, well, I come from the UK perspective of really being overworked and just not finding time in their day. Yeah. If I can, I'll ask the lady behind, sorry, sir, I'll ask the lady behind you and then sir here and then here. Yes, please say your name and where you're from and your question.
Hilary Nathan, associated with the International Agency for Research on Cancer. And my question was beyond, I guess, the practical challenges of people getting access to well, it should be relatively easy to be vaccinated, or just being, I guess, a little bit ambivalent about it, not knowing how important it is. Why is it that you think that the anti-vaccination campaign has become such a powerful voice that really has a social media impact and things like that? Where has that come from, and is there any foundation in that, and why? How do you look to actually contradict that messaging? But really, for me, it's just a general curiosity. Why has it become so powerful?
Yeah. Yes, indeed. And we all think about that study which was wrong about MMR, measles, mumps and rubella causing autism, and that just does stick, doesn't it? So excellent question, Otmar. Yeah, what do you do to counter that message that vaccines are evil?
I can only speculate at this point, and that is, it is something that has not been fully researched. Certainly there are a lot of mistakes and errors in the risk perception that people have. Because what we see is, this is, as I said before, is not necessarily an undereducated group. It is a usually well-educated group, and it's a problem in affluent countries. So the countries are rich enough. Now, one of the things that comes with that is that they have not seen the problems with the disease themselves. They think that those diseases are remote. They themselves don't get the disease. It doesn't happen to them. And if it happens to them, they think it can be taken care of. Many people believe that you can take antibiotics against the flu. That is a misperception as well. There is not really very much you can do once you have acquired it. You can have it against secondary infections then, that's certainly true and is very important. But there are these misperceptions is, I don't get it, I don't spread it, it can be easily treated, which are wrong. And then, of course, some people have a lot of time to unfortunately read nonsense. And that is being spread with the electronic media quite a bit. And I find it very often combined and see it in people which also believe in other very questionable, no evidence methods of treating diseases. And that really is a problem there. But to me, quite interesting, it is a matter of affluence. We don't see this problem that much, for instance, in poor countries, where you have the disease next door, where people are suffering from it and they can really see what it means to be ill. And in those countries, the resistance against the vaccines, against the immunization in general, is much lower there.
Indeed. Matthew and then Luke.
I think it is a really important question and a very good question. I think there's work that needs to be done to address the myths that surround, particularly flu. I mean, you sometimes hear, when you get the flu vaccine, you get the flu. Oh, it's like, well, you don't. we don't administer a live flu virus up someone's nose or into their mouth. We administer, or vaccine manufacturers administer subunits of it, killed subunits of it, or formulations of it that basically don't give you the flu. You may have some localized response, and Otmar can certainly talk to that far more than I can as a clinician. There's localized response, and maybe there's an elevated temperature, but that's kind of unique. That's bespoke to all kind of vaccines, and often linked to the adjuvant that's formulated with that product. So there's certain myths that need to be dispelled. I think the MMR example really does stick, even though it's been refuted, and quite publicly so, in several ways.
We've seen in the US the whole anti-measles vaccination.
Yeah, exactly. And then the other myths, I think, is regarding things like side effects. So it's not just about getting the flu, it's the actual side effects. And yet vaccine manufacturers work, very diligently to make sure that the vaccine that they produce is safe, is efficacious, satisfies all of the necessary regulatory authorities, the pharmacopoeia methods that are required. There's a very significant regulatory path that has to be gone through before a vaccine can be commercially available, etc. And a lot of that involves toxicology, preclinical testing, as well as clinical testing, and a lot of that is to assess the safety as well as the efficacy. So there's a lot of myths, dare I say it, that need to be kind of addressed and put to bed, essentially.
Indeed. Luke?
I think also, from the very early stage of immunizations techniques, it has happened. You had very strong opponent of that. I think the challenge is that the risk, the analysis that people from maybe the medical community assess a risk is quite different from how an individual would create the risk image within him or her. There's different factors. One of them is whether this risk is something that is imposed on you or not, whether you find that this risk is avoidable or not, and whether you fear what is prevent it from. So there's really a lot of factors that has been described over the time. I think what is now happening is that the social media and other medias makes it more relevant to disseminate that, and you start to have the question on whether you need to answer very alternative facts that are not relevant and not evidence-based, because it will give more credits to this fact, or whether you need to say, well, I need to only focus on things that I don't want to make advertisement, even if it's negative on something, because that will raise suspicion. What is quite interesting is that you will, if in each country in the world, you will find different side effects that are claimed to be on vaccines. So for instance, in France, it would be primarily around the hepatitis B vaccine that has been highly attacked with sclerosis. The measles part has not been very highly visible there, but on the other hand, in the UK, that's more the measles, and the hepatitis B was not so much a concern there. It's also raised the question whether it's also, for me, an element to say, well, you don't have the same concern, you don't have the same data in any way. So that's really challenged us to say, why is it only in the UK? And I think the question is because maybe there's not really a strong evidence on the measles there, and whereas in France, why is it in hepatitis B? Because there's misconduction there. So there's a lot of element around determining the risk, how the risk is translated into the mind, because people will not really relate to numbers, they will relate to what it means for them.
Yes, indeed. And yes, I think that good journalism is needed, and there's not always good journalism in the UK, which likes the scare stories, it has to be said. Sir?
On this last point, the link to autism and measles vaccination, there is a book, Panic Virus, written by Mnuchin or something. But Panic Virus gives a very in-depth insight in how that risk perceptions and the myth are built, strategically built. And basically it's built on people have a belief system. The belief system is so strong, and people are going out to find results from and debates to fit their belief system. And it's very, very nicely written, and then you suddenly understand why it's so difficult to talk about this, because if CDC really goes out to give a very balanced and honest response to benefit-risk ratios, etc., the people just give a twist to the answer and blame the CDC for admitting what's wrong and why they are right. So what you see happening in that book, it's beautifully described, is the psychology behind it and how people really build it. And in the scientific community, we're talking about evidence-based, and we are very sophisticated in language. Well, that are two different worlds.
Yeah, yeah. Yes, indeed. Getting messages across, we know, which are evidence-based, especially to the British population, is not always easy.
I just want to make a comment on Luc's suggestion, very practical suggestion, or it was Otmar, I think, to bring the vaccine to the healthcare work.
Yes, where people spend 8 hours of their day. Yes.
I think that is very important, and it works where it works. But if people are not convinced about the benefits of the vaccine, it doesn't work. Because then, at that stage, they won't come. Because it's easy maybe, but they're not convinced it's for them.
And that's what we saw in the US, where only 50%.
And I've seen also examples.
No. I think you have a group effect if you bring it to the workplace, because then it is difficult for people to evade from that. You are by your peers. You are then in a position that you have to explain yourself. While if it is done like in other countries, that you have to go individually to another place, to a clinic, an occupational health clinic, and get it, there is the inconvenience of going there, there's an inconvenience of time to wait, and you do this individually, so you don't have to explain to others. So I think if you have this in the collective, it is much more difficult to explain why you don't want to be protected and why you want to stand out. So I think there is a multiple benefit of that. I think it's much more economical to do it, But I think there's also from the group dynamics, it's a much stronger pressure in doing this with this.
I agree fully. But when it's not used in the system, then it's difficult to get enough people, the critical mass, to make that habit. Once that habit exists, you have your social responsibility and the mechanism.
Yeah, I mean,
so I think we still need to convince the healthcare workers that it is something good to do.
And the other people can be used as guinea pigs. Your colleagues will be prevented. And if some of those who are not immunized, you have these elements. And I don't think it's only to have one time and that's it. I think it's about building it over and over. So then you build this habit within and culture within the organization. Yeah. So if you're not convinced the first time, or if you have doubt, the other colleagues will be able you will be able to look at them and say, well, I was sick, they were not. So maybe next year I want to change myself. And I would say also another example of groups is also the teachers, or those who are handling with a lot of kids or adolescents. That also is a crucial element around conveying and being a model there.
To get to this tipping point. So yes, let's take a final question.
Thank you. The final question, yes. Fighting the flu, yeah, it is everybody's business, because it is concern the society. Mm-hmm. It is medical issues, but it is also social issues. It should be social issues. It must be social issues. It is social issues. This is my question. But as I hear World Health, how do you say? No. Workers.
Yes, healthcare workers, yes. Nurses, doctors, in simple English.
Workers, yes. I should invite you all to the World Health campaign, international campaign, launched since 2 years ago during the International Red Cross conference. It is concerned all the professional and paramedical. Yeah, it is, I forgot the name of he's in charge, he's Special Representative Ban Ki-moon, but he's still in New York, between New York and Geneva. But my question, it is about the social issue. I want to hear you about that. Thank you.
The social issue, can you be a little bit more precise on?
You was agree? Yeah, my thought.
How we
it is medical issue, it is social issue.
Yes.
And it is very strange that we have this global efforts to get the best possible vaccines around, and we basically ignore to a large extent the possibilities to have the benefits from these products. Yep. It's strange.
I was just thinking, from the healthcare worker position, might there be some sort of advocacy or a kind of drive to ensure that at least people who have the high patient contact, whether they're in the community, whether they're on the hospital wards or whatever, what might be kind of the driver to force, in inverted commas, them to become vaccinated? If you think of like society nurses or doctors that work within society medicine or communities, they may have a contact of 1,000 people per week. Well, that's a phenomenal contact rate. So might there be some kind of instruction or drive to say, as a result of your job, you have to have a flu vaccination?
What we found is, and that is work that has been done by psychologists on that, is that the usual argument, protect yourself, doesn't resonate that well with health professionals. What you have to make them aware of is you are not only of risk yourself to acquire the disease, because that's something they are not really that worried about, interestingly. But they are very responsive when you tell them you are putting your patients and you're putting your family in danger.
Yeah. The grandparents who are putting their children or grandchildren at risk.
You yourself, yes. Your children at home, you come at home, your spouse, your children, you carry this home with you, and you carry this to the next patient room. Yeah. When you have it, even if it's without symptoms with you, you still may be a vector in doing this. And that is something that has a higher appeal and works better than telling them protect yourself, because that is not really that much on the radar there.
Understood.
That relates to do no harm, right?
Absolutely. Absolutely.
We've Erica, one quick thought, then I'll go back to the panel for their thoughts before we wrap
I just
up.
wanted to reinforce that message that you just conveyed, because we know that healthcare professionals, nurses and doctors, always put themselves before the patient, right? That's the whole idea. And very, very often we're not thinking about ourselves. We don't sleep. We don't, we lift patients when we shouldn't. We're always putting patients before us. And so really, I think it's very, very important to have that message. We don't really care about ourselves. Who we do care for is the patient. And so to have that and reinforce that message is very, very important.
Yeah, the healthcare worker about the patients, and generally everybody about the impact on society. Yes, definitely. If I may then ask, let's try and counter the social media who specialise in tweets and sound bites for some of the myths. Luke, let's have a sound bite to end and a tweet about what's it going to take, what's the one thing to make sure that fighting the flu is everybody's business.
I think it's, I'm immunized for myself, my patients and my family. That's what I think Otmar has been saying, and I think it's very reflecting what we hear.
Sarah's writing down that slogan. So we're turning this now into a workshop on communications and slogans. Matthew.
I think Luke has summarised it really very nicely in those few lines there. I think, one of the aspects is to consider the opportunities and the different requirements to improve flu vaccination uptake in workplace. We've heard of the different dynamics in the clinical field. I think that needs to be rolled out to other areas as well. So it's considering the opportunities to improve vaccine uptake.
Yep. Otmar.
Well, I would make an appeal to the employers and saying, provide immunization to your staff. It's easy, it's cheap, it's safe, and it produces a high return on investment, and as well on a humanitarian as on an economic basis.
There we are. We have the messages. We just now have to go out and deliver them to some of the groups. Thank you very much, Luke, Matthew and Otmar, and thank you all for your very good questions. Thank you.